Dr. Cassidy has been a consultant in stroke medicine for over 30 years. He returned to Ireland from the UK 10 years ago and took up a consultant post based at St. Vincent's University Hospital and the Royal Hospital in Donnybrook. Dr. Cassidy is also chair of the Irish National Stroke Audit Committee, and this committee has been set up to improve the quality of stroke care across Ireland. And as well as that, he is also very active in stroke research, both locally and nationally, and has over 70 papers accredited to his name. And then, just as an aside, many of the members who use our services speak extremely highly of Dr. Cassidy and his care. So look, we are absolutely delighted he's here today, and I will now hand over to Dr. Cassidy to take over now. Thank you, everyone.
Thanks very much, Helen. And thank you for inviting me. And more importantly, many thanks to the Irish Foundation for all the work they do with our stroke patients and stroke families. So if we start off with the first slide. So as we've said, we've go back to the first slide. Yeah, so for hundreds of years, people have worried that if you have a mild stroke, which is apoplexy, that you are at risk of further stroke disease. And this was a French philosopher in the 16th century. The next slide, please. So stroke was originally described by Hippocrates, who lived around about 450 BC. But actually the first description of stroke was written approximately 100 years before that. And it's a psalm written about the Jewish people's exile in Babylon. And when I read this, I think of a patient who's suffered a stroke. They've got a paralysis in the right arm and hand, and they're aphasic. Their tongue is stuck to the roof of their mouth. So we'll go on to the next slide. So we're going to talk about Peter. And we're using Peter just as an example of how we should think about secondary prevention. So Peter's a 70-year-old man. He has a history of diabetes and hypertension. And he presents with a 4-hour history of right-sided weakness. So the questions we ask ourselves is this a stroke or is this a TIA? And I'm going to describe the differences between the two. Now, the important thing from the point of view of stroke is the significant cost it has. And the next slide shows stroke is the third leading cause of death, and it's the leading cause of severe disability in the community. There's significant economic costs and the direct costs of the patient being in hospital, the hospital team looking after the patient. Indirect costs are the point of view of the loss of revenue for the patient or the family, and looking after the patient in the community. While stroke is assumed to be a disease of the older person, 1 in 4 strokes occur in people aged less than 65 years. So, contrasting what has happened over the last 40 years. In 1983, when I was graduating, if you came into hospital with an acute stroke, we took a history and we examined the patient. We gave the patient some IV fluids. Ward care was very much based at the bottom end of a Nightingale ward. Some patients got therapy. We didn't know whether to use antiplatelet agents or whether to use warfarin. Today, we live in a totally different world. We live where history and examination are critically important. We've got brain imaging. Some patients are eligible for hyperacute treatments, and all patients are eligible for stroke unit care. Our secondary prevention is now based upon investigations and good research materials. Going to the next slide, we have to realize that a patient who presents with neurological symptoms, there is a large differential diagnosis possible. And even today, we get fast calls down to our emergency department. And our job is to differentiate stroke patient from a stroke mimic. On the next slide. So what's the difference between a stroke and a TIA? Now, when I graduated 40 years ago, a TIA, transient ischemic attack, was a patient whose symptoms had resolved within 24 hours. If that was the case, we're using hyperacute treatments and we're treating transient ischemic attacks. But we know that if we wait 24 hours, we've lost that opportunity and we need to intervene sooner rather than later. The new definition, which has come about, particularly in the United States, is that a TIA is a patient who has symptoms of less than 60 minutes and in which there is no evidence of damage on their CT imaging or MRI imaging. So we're moving from a very much old tissue-based definition into a more modern definition based upon our imaging. So the role of brain imaging, the CT brain scan is the workhorse of stroke medicine. It quickly identifies potential stroke patients and excludes other things. As I was taught 30 years ago, and as I still teach now, on a CT scan, we don't want to see anything white. White means blood. Black means dead brain, or strange looking means query tumor. We use far more MRI scanning nowadays compared with previous, and we sometimes see normal people who have abnormal MRI scans. The next slide. So we can very simply, if we look at stroke, the majority of strokes are infarcts. And that is that there's a clot which has blocked a vessel, and the vessel is blocked, and therefore there's damage to the brain. And our hyperacute treatments are used either thrombolysis, clot busting, where we dissolve the clot, and or thrombectomy, where we pull the clot out by my colleagues at Beaumont Hospital. Approximately 15% of patients who present with a stroke are due to a bleed, and that can be a bleed within the brain, what we call an intracerebral hemorrhage, or a bleed outside the brain called a subarachnoid hemorrhage. If we take our patients who've had an ischemic stroke caused by a clot, we can divide them into lacuna strokes, about 1 in 4, or non-lacuna. And we can subdivide the non-lacuna strokes into strokes caused by cardiac problems, large artery problems, or other causes. And then there is this small but significant number of patients who we describe as cryptogenic. And that is where we haven't found an obvious reason. Those cryptogenics, we sometimes think of an embolic stroke from uncertain source, a non-embolic stroke from uncertain source. And then on the next slide. So this CT scan, patient had come into St. Vincent's Hospital, 76-year-old man, and the radiology registrar reported the stroke. This patient is having a right middle cerebral artery infarct. So we have the left side of the brain over here and the right side of the brain here. And you can see this black area here. Going back over, we were asked to see him, went to talk to him. And what we found was the patient had a 2-week history of increasing left-sided weakness. So it had got worse over his 2 weeks. The patient had evidence of cognitive impairment and was ignoring things on the left-hand side. That raised clinical suspicions, and the patient ended up having an MRI scan, which detailed that this wasn't a stroke, but was another neurological disease. So it again emphasizes the importance of taking a history. And the next slide. Again, CT scan done on admission. And the arrows, the black arrows, demonstrate blood on the outside of the brain and between the skull. This is a patient with a subdural hematoma on both sides of the brain. And knowing that, we know that the patient hasn't had a stroke, and therefore we should stay away from clot-busting drug treatments. On the next slide. And this shows a CT brain scan. As I say, nothing black, nothing white. Here you see a large area of whiteness, and this is blood. This tells us that this patient has had an intracerebral hemorrhage. There's some white areas down here. That's quite normal. That's called the choroid plexus, but this is abnormal. On the next slide. So secondary prevention. We ask ourselves, is this a stroke? What type of stroke is it? What is my patient like? And what are we trying to achieve? So if we go, so from the point of view of stroke prevention, and somebody who's had a clot in an artery causing an infarct, we think about large vessel disease, small vessel disease. We think about heart problems. Has the patient got an irregular heartbeat, atrial fibrillation? Have they got a valve problem? Or have they got what we call a patent foramen ovale? Now, PFOs are quite common. They occur about 1 in 4 people, but they sometimes cause stroke, particularly in the younger patient. There are metabolic causes of stroke, genetic causes of stroke. And then, as I said, there's a small but significant number of patients who, despite extensive investigations, we never find out the reason why. So we go to the next slide. I think we're back talking about Peter. He's had a stroke. There's no evidence of any bleed on his CT scan. His MRI confirms a small left hemisphere stroke. So what are we trying to do? We're trying to stop Peter having a second stroke. And more importantly, we're trying to keep him well. People ask me, well, what's the risk of a stroke after a minor stroke or a TIA? The risk is high, particularly in that first 7 days. There's a high early risk of stroke, and that risk tends to level off. So by 12 months, that risk is running around about 6% per year. We used to, and I'll look at the next slide, think that strokes which occurred in the back part of the brain, what we call the posterior circulation, are associated with less recurrence. But this study, which was published in the Lancet Neurology 12 years ago, show again, this is percentage of survivors. Again, you see that rapid drop off in that first 2-3 weeks. And if you've got evidence of intracranial artery narrowing, your risk is far greater than the patient who has no evidence of arterial narrowing. So, good. So I divide, when I see a patient, I think about non-modifiable and modifiable risk factors. The non-modifiable risk factors are things I cannot change and alter. We know stroke prevalence increases with age. It appears to be more common in men compared with women, but that's probably an overstatement, in that men have a rapid increase in stroke in midlife, whereas in women, that increase in stroke in females tends to occur in older patients. Family history is particularly important when we're dealing with strokes in the young patient. So we as doctors tend to concentrate on the modifiable risk factors. What can we change with medicines? What can we suggest from the point of view of lifestyle changes? So the first question I ask about Peter is, does he have large vessel disease? And by large vessel disease, I'm talking about the internal carotid artery. He's had right-sided weakness, therefore is stroked in his left brain. And does he have narrowing in his left internal carotid artery? We can image the carotid arteries using an ultrasound scan or a CT angiogram, and we can divide the narrowing into mild, moderate, and severe. For people with mild narrowing, medical treatment is needed. And for the next slide, and for people who have moderate to severe narrowing, surgical treatment is the preferred option, and particularly with people who have severe narrowing, so that's greater than 70% stenosis. Some people ask me about stenting. Well, actually, surgery is better than stenting, apart from some selected patients. There were two trials done in the 1990s, the European and the North American studies. And these were people with severe carotid narrowing. With best medical therapy, 16.9% of patients suffered a second stroke. But if they had surgical treatment, that fell down to just under 3%. And the North American studies showed similar benefits of reduction, relative risk reductions of 60 to 80%. The differences in the two studies are explained by the fact that the Europeans measured things slightly differently to the North Americans. We know that this treatment is applicable to patients who've had a TIA or minor stroke. We also know that early surgery is better than late surgery, and that the benefit of early surgery outweighs the risk of one of my colleagues in surgery opening up your neck. And the next slide. What about blood pressure? And this is applicable to all stroke patients, whether they've had an infarct or a bleed. And our goal is a systolic blood pressure of less than 130. To me, there is look at that statement and think, does the patient with a blood pressure of 128 millimeters of mercury, that's normal, compared with the patient with a blood pressure of 132 millimeters of mercury, and that patient would be defined as hypertensive. But it depends upon the patient. When do we introduce treatment? Well, usually I wait several days unless the patient is undergoing hyperacute treatments. There are situations where rules don't apply. Individual patients, some patients who have bilateral severe carotid artery disease, we want a higher blood pressure. I always recommend home blood pressure monitoring and at least annual checkups by the general practitioner to ensure that the patient's blood pressure is less than 130. And in some patients, we try to push it down even more. We know that reductions of 10 millimeters of blood pressure will reduce cardiovascular disease and reduces stroke by 27%. So occasionally when I was living in the UK, I would be in Sainsbury's shopping with a 7-year-old terrorist, and somebody from the Stroke Association would measure my blood pressure. And my blood pressure undoubtedly was high, shopping with a 7-year-old terrorist. Next slide, please. Lipids, and the goal is a reduction in the LDL cholesterol to less than 1.8 millimoles per liter. It's a combination of lifestyle interventions and medications, which are the statins. If the statins don't work, or if we don't achieve that target LDL cholesterol, there's the ezetimibe, which can be added on, or the newer PCSK9 drugs. The evidence for using lipids in stroke patients is based upon various cardiology trials, which have taken people who've got ischemic heart disease and shown benefit in stroke reduction. And then specifically the Sparkle trial, which took a group of patients with stroke, TIA, and randomized them to high-dose statin versus placebo. And they showed benefit from the point of view of reduction in stroke, and also, more importantly, coronary events. We use antithrombotic medications, particularly when strokes are caused by a clot. And what we're trying to do is thin the blood down to prevent clots. And I tend to think of two things. One is, does the patient have a normal heart rhythm? Or does the patient have evidence of atrial fibrillation, either sustained or paroxysmal? For people with sinus rhythm, we use high-dose aspirin and follow that up with long-term clopidogrel therapy. I'm going to talk a little bit later about dual antiplatelet therapy. The TARDIS trial was done approximately 12 years ago, and they used triple antiplatelet therapy. That was aspirin, clopidogrel, and this drug, dipyridamole, but it showed no benefit. Some of the questions I ask myself is, what happens when the patient's already on prior antiplatelet therapy? Do we need to change it? And we'll discuss that again shortly. And people with atrial fibrillation, anticoagulation should be initiated unless there's a specific contraindication. We know from the ELAN trial, which was published last year, that we should start anticoagulation sooner rather than later, particularly in the minor and moderate strokes. And the major strokes, we should wait 7 days at least. The RESTART trial took an interesting concept. It took a cohort of patients who'd had a hemorrhage. Prior to the hemorrhage, they were on a drug such as aspirin or clopidogrel. And the clinician randomizing the patient into the trial using the principle of uncertainty, either randomized the patient into restarting their aspirin or clopidogrel following the hemorrhage. And the patients were randomized over 2 months since their bleed. They were followed up for 2 years. But again, the study, while small, tended to suggest that there was benefit in restarting antiplatelet therapy following a hemorrhage. We don't as yet have that evidence for restarting an anticoagulant. So what about dual antiplatelet therapy? Well, the POINT trial was published 7 years ago. It used aspirin and clopidogrel versus aspirin alone in the minor acute ischemic stroke patient and high-risk TIA. On the right-hand side, we see two graphs. You look at the top graph, the red, this is the incidence of new strokes against time. And you can see if you're on dual antiplatelet therapy, there is less risk of a second event compared with aspirin. However, being on two blood thinning drugs, there was a slightly increased risk of bleeding. The POINT trial treated people for 3 months. Using the evidence from POINT trial, we now use dual antiplatelet therapy, but for a much shorter period of time, approximately 3 weeks, before converting to one drug, which is usually clopidogrel. The next slide. So this is another trial which compared tiagrelor and aspirin versus aspirin alone. Tiagrelor is the son of clopidogrel, and it showed, again, looking at the top graph, it shows that tiagrelor and aspirin was significantly better than aspirin. But again, the dual antiplatelet therapy caused more problems. So why use tiagrelor? Well, clopidogrel is what we call a prodrug. It needs to be metabolized in the body into its active form. And there's a certain number of people who have a genetic predisposition and they cannot metabolize clopidogrel into the active drug. So when people have had a stroke, a second stroke on clopidogrel, I tend to think about this. Have they got a genetic predisposition? And I will switch to tiagrelor. The genetic predisposition is more common in the Chinese population, but the actual prevalence of this genetic problem, we presently don't know. There are other treatments available from the point of view of stroke secondary prevention, some of which have not taken off in the population. The insulin resistance in stroke trial took a group of patients who had an ischemic stroke. These patients were not diabetic, but were shown to have insulin resistance. And again, this is the hazard ratio, and you can see that people on pioglitazone had fewer secondary events. This trial was published in 2015, 2016, hasn't really taken off. And the problem was with pioglitazone, it caused weight gain, increased risk of fractures. And halfway through the study, we were reconsenting patients because there appeared to be an increased risk of bladder cancer. But there are newer drugs, newer trials out there, and credit to Professor Peter Kelly at the Mater, who ran the CONVINCE trial last year, is looking at recruiting patients into a CONVINCE 2 trial. Next slide, please. So Peter's a diabetic. He's had a stroke. Diabetics have premature vascular aging. It's a strong risk factor for stroke. 30% of stroke patients are diabetics. If you're diabetic, you have twice the risk of stroke compared with non-diabetics. They often have worse outcomes due to their comorbid diseases. And long-term, the risk of stroke is higher compared with non-diabetics. So traditionally, the management of diabetes has been decreasing the hemoglobin A1C, which is a marker of diabetic control, treating comorbid conditions, and using antithrombotic treatment, which may be aspirin or clopidogrel. We know that there is evidence for aggressive multifactorial approach can reduce vascular risk compared with conventional care. The question to be asked is there a role for the glucagon-like peptides, receptor agonists? And traditionally, we talk about these drugs as Ozempic. And the next slide. The next slide looks at these agonists, looking at dulaglutide and semaglutide is Ozempic. They took 8 trials. And each trial itself was not statistically significant. So what they did was they did a meta-analysis. So if the little dot is to the left of the 1, it is significant. If the confidence limits cross the value 1, it's statistically not significant. But if you combine all these 8 trials together into this meta-analysis, you see several things. 1, the odds ratio is less than 1, suggesting benefit. The confidence limits, which have now shrunk to a small area, suggest that the trials are statistically significant. So there appears to be benefit in fatal and non-fatal strokes, and certainly benefit with non-fatal strokes using these agonists. From the point of view of fatal stroke, whilst the odds ratio is less than 1, the confidence limits touches the unity value. Next slide. Yep. So how do these drugs work? Well, yes, they improve diabetic control, reduce weight, and therefore reduce blood pressure. But they also appear to have benefits on the vessel wall. They improve vessel dilatation. They reduce inflammation in the walls of the vessels. And they help the smooth muscle. There also appears to be some evidence that they protect the brain, and so they improve what we call neuroprotection. And the next slide. So just moving away from Peter for a moment, sometimes we're asked about other risk factors, particularly in women. The contraceptive pill is associated with an increased risk of stroke and secondary prevention, combined oral contraceptive pill. And therefore, we have to advise young women that they should use progesterone-only pills or non-hormonal forms of contraception. Point of view of the postmenopausal women, some are on HRT therapy, and we talk about the risks and benefits with them. A Cochrane review looked at 19 trials using HRT treatment in 40,000 patients, found no benefit but increased risk of stroke in patients who were previously fit and well. I think the important thing from the point of view of hormonal treatment is also looking at their other risk factors. Obstructive sleep apnea, it is common. Often people who have obstructive sleep apnea have other vascular risk factors, but obstructive sleep apnea is an independent risk factor. I saw a patient in clinic yesterday who'd been worked up on the medical admission unit. And when I saw him yesterday in clinic, He was accompanied by his wife. And when I asked the wife about his sleeping, I got a history of loud snoring, episodes where he appeared to stop breathing, which is characteristic of obstructive sleep apnea, and he scored high on the Epworth Sleepiness Scale. So this gentleman was referred to my colleagues in respiratory medicine for confirmation of this presumed clinical diagnosis, and secondly, if that is the case, to intervene for this gentleman, because treatment of obstructive sleep apnea will improve outcomes. So what about lifestyle measures? Physical activity is important, and often the patient who has had their stroke as an inpatient becomes deconditioned. We need programs to improve fitness and muscle strength. I often talk about walking daily or trying to link patients into community-based exercise programs. That might be a personal trainer. Next slide. I have a personal trainer, and for at least 4 days a week, this personal trainer takes me out on a trot of at least 60 minutes. Next slide. Smoking is still common, and 1 in 4 stroke patients have had a stroke. Smokers have an increased risk of stroke. We should look at our nutrition, both from the point of view of reduction in our BMIs. Mediterranean diet has a positive benefit in reduction in blood pressure, small decrease in our lipid profile. Stroke patients ask me about alcohol. I say alcohol in moderation. It's recommended about 14 units per week. And the next slide. These are my final thoughts and observations. And perhaps we can generate some debate in the question and answer session. Okay, and the next slide. So we live in an aging society. Our population of people aged over 80 will increase threefold over the next 30 years. We define frailty by a loss of physiological reserve to withstand a stressor event. And this results in increased susceptibility to illness. And then next slide. So it really is a clinical syndrome. It's distinct from disability and multi-morbid conditions, but there is considerable overlap. About 1 in 4 stroke patients we deal with have evidence of frailty. And the next slide. Frailty assessments are being increasingly done. There's relatively little research into whether frailty exerts a treatment-modifying effect on our secondary prevention strategies. Are statins of benefit in people who are frail? Possibly not. Trying to get our blood pressure down in patients with moderate to severe frailty may actually do more harm than good. We know that carotid artery surgery, revascularization, there's an increased risk of periprocedural stroke in our patients who are frail. And needless to say, the use of anticoagulation also causes an increase in composite endpoints in our frail patients. And the next slide. Okay, so where are we in medicine? This South African Danish American tells us that sometime in the future, AI is going to replace me. And there was a book written 15 years ago talking about the end of medicine and the last doctor. So we go to the next slide. And recently there's been 2 articles, one published in the Washington Post and another done in the Wall Street Journal, about how Dr. Google is helping patients. In the United States, we know that 1 in 3 people will consult some type of AI device prior to seeing their doctor. The younger population, those aged less than 35 years, and nearly half of them will consult AI before seeing their doctor. AI has certain problems. It can cause hallucinations. That is a technical term in which the AI comes out with what seems to me quite a sensible statement, but is actually incorrect. The AI benefits in that it provides tools to support your care. It excels at providing clear explanations. It is also of use in rare diseases. So if you see somebody with a rare disease, the doctor will go away and research it. AI does it in seconds. The problem is self-diagnosis. If you develop an arm weakness, do you consult your AI? Or do you call the ambulance to take you into hospital? There is a worry that self-diagnosis patients may delay seeking medical help. The other concern which we have is you input into this AI device all your health information. How secure is that? We know AI is evolving. Next slide, please. But is it as good as it's made out to be? Recent case report in the New England Journal of Medicine, where Dr. Dahlia took on an AI tool called Dr. Cabot. And this was a clinical pathological discussion, competition, and the human won at the end of the day. Last week in the Irish Times, there have been concerns raised by the Medical Council with regard to AI being used, particularly by doctors. And this is going to bring significant challenges for all of us in the future. Next slide. Is AI good? Well, if you show them a picture of a chihuahua or blueberry muffin, the human wins. The human is able to pick out the chihuahua as distinct from the blueberry muffin. And the next slide. The last thing to comment upon, and I'm aware of this, is that there are remedies touted on the internet. Some of them are good, some of them are the medical equivalent of snake oil. And I think to look at something on the internet, you need then to discuss it either with your primary or secondary care physician to see whether it is of benefit to you or whether it is the 2025 version of snake oil. And I think, next slide. Oh, so how can we make things easier? This is from the American Heart Association, a list of questions for the medical team, and that could be in primary, secondary care, to take, and recommendations across. Now, obviously, some of it involves the American lipids, which are in different units to what we use in Ireland. But it is a sort of good way of looking at those 12 risk factors in a patient and identifying risk factors that can be modified. Thank you very much. Happy to take questions.
Excellent. Thank you so much, Dr. Cassidy, for that presentation. There's lots of comments in the chat saying many thanks, and people found it extremely informative.